Thank you very much for your patience. So why should we study upper GI bleed? Because it's a common emergency. It requires rapid diagnosis and stabilization of the patient at the same time. Now, today we're going to focus on one part of GI bleed, which is upper GI bleed. Now, if you want to really appreciate this whole GI bleeding thing, one structure you need to really master is what we call the ligament of Trias. And with the ligament of Trias, that's what I'm putting the cursor on. So if you look at the diagram very, very well, the ligament of Trias is what separates what we call the upper gastrointestinal tract from the lower gastrointestinal tract. So all the structures above the ligament of Trias, so you know, the esophagus, the stomach to the upper part of the duodenum, they all come proximal to the ligament of Trias. That if bleeding is coming from any of those parts, that's what we call upper GI bleed. And if bleeding is coming from the lower part of the GI tract below the ligament of Trias, that's what we call the lower GI bleed. Okay, so when you are thinking about gastrointestinal bleed, please think about it in the context of the ligament of Trias, the ligament of Trias. Now, so today we're going to focus on upper GI bleed, just the upper part, because if you are learning this concept, you need to learn it in terms of which ones form part of upper GI bleed, which ones form part of the lower GI bleed. That's why I'm saying that it's a series of lectures we'll be having. And today I want us to focus on the upper GI bleed alone. Okay, so doctors, if you fell off, please join again. We are back. Now, how should you approach GI bleeding? How should you approach gastrointestinal bleeding? You realize that in classic cases of upper GI bleeding, the history, the physical exam, the diagnosis usually have to occur simultaneously with resuscitation, your resuscitation efforts. The reason is because people who have upper GI bleed, they can sink quickly. Okay, and in most cases of upper GI bleed, the patient may be unstable. So one thing you have to do in your board exam is you have to learn how to stabilize the patient while you are investigating. Stabilize the patient while you're investigating. Don't say that, oh, I'm going to get my CBC, wait for the results before I do something about it. No. While you are getting your CBC, while you're setting your IV line, you are setting IV fluid, you are giving blood and all those things. That is how serious GI bleeding can be. Now, this is a very important concept I want you to write down in your books right now. Write this in your book right now. What are the factors that increase morbidity and mortality in patients with upper GI bleeding? What are the factors that increase morbidity and mortality in upper GI bleeding? For your board exam, remember 3 things. For your board exam, please remember 3 things. Number 1, old age. Please, number 1, remember old age. Number 2, if you have a patient who has a coexisting organ disease, so like liver disease, like heart disease, like kidney disease. Number 3, a patient who has had recurrent upper GI bleed. Please, this is very, very important for your board exam. And that is why I'm taking time to really, really emphasize on it. What are the factors that increase morbidity and mortality in upper GI bleeding cases? The first thing you need to remember is older age. So if you have somebody who is, say, 60 years, as compared to somebody who is, say, 20 years, both of them have been diagnosed with the same cause of upper GI bleed. Which of them have a higher risk of mortality and morbidity? It is the older patient. Number 2, which of the people has a higher risk of increased morbidity and mortality in a patient who has had upper GI bleed? It is the person who has a concomitant organ disease, like heart disease, like liver disease, like kidney disease. And number 3, a patient who has had recurrent hemorrhage, recurrent bleeding. So let's try some MCQs right away. The first question is this, please, and I need you to type quickly. Which of the following best defines upper GI bleeding? Which of the following best defines upper GI bleeding? A. Bleeding distal to the ligament of triads. B. Bleeding proximal to the ligament of triads. C. Any bleeding between the esophagus and the rectum. D. Only bleeding from the esophagus and stomach. E. Only bleeding seen at endoscopy. What's the correct answer? What's the correct answer? Is it A? Is it B? Is it C? Or is it D? Good. This is very simple because we've gone through this concept. Bleeding which is proximal to the ligament of triads. That's the correct answer. Upper GI bleed is defined as anatomically as bleeding which is proximal to the ligament of triads. Any bleeding which is distal to the ligament of triads, that is lower GI bleeding. Next question. You have a 75-year-old woman who presents with melena and hypotension. Which of the following factors most increases the risk of morbidity and mortality? A. Normal renal function. B. Use of proton pump inhibitors. C. Coexistent ischemic heart disease. D. Female sex. E. Initial hemoglobin of 120 grams per liter. So this question is testing your knowledge on factors which increase morbidity and mortality in upper GI bleeding. Okay, looks like a lot of doctors got it right. The correct answer, according to what a lot of doctors are writing, is basically C, coexistent ischemic heart disease. Okay, that's the correct answer. We learned that the factors which increase morbidity and mortality are three. Number one, increasing age. Number two, coexisting organ injury or organ damage. Number three is a history of recurrent bleeding. Please note this very well. Okay, now, what are the causes of upper GI bleed? This time, I'm going to use what we do in MedCognito by giving you an equation. And then you are going to look at the equation and then tell me the various causes of upper GI bleeding. Let's solve them with mathematical equations. So number one, this diagnosis is the most common upper GI bleeding cause. There is gastric or duodenal mucosal defect. What diagnosis are we talking about? The most common upper GI bleeding cause. There is, if you do an endoscopy, there is gastric or duodenal mucosal defect. What diagnosis are we talking about? The most common cause of upper GI bleed. So, number one, this question is testing you on two things. Number one, you need to know the most common cause of upper GI bleed. And number two, you need to know the cause of GI bleeding, which causes gastric and duodenal mucosal defect. So what's the correct answer? So I see a lot of doctors going for peptic ulcer disease. What's the correct answer? The correct answer is peptic ulcer disease. So please write this in your book. Peptic ulcer disease is the most common cause of upper GI bleed. And in peptic ulcer disease, you see gastric or duodenal mucosal defect. Okay. Next question. You have a patient who takes NSAIDs, so like ibuprofen, naproxen, Toradol. He also takes alcohol. And when you check the GI tract, what you see is diffuse mucosal erosions. Diffuse mucosal erosions. What is your diagnosis? NSAID plus alcohol plus diffuse mucosal erosions. What is your diagnosis? I want to know. What is the diagnosis? Please don't forget, tell your friends in the WhatsApp groups, tell your friends to join us right now. Class has started. Diffuse mucosal erosions in a patient who takes, look at this one. I didn't say it has, any craters or gutters or anything like that, right? This time the patient has diffuse mucosal erosions. What's the diagnosis? So the diagnosis, please, this time I see someone writing Bohaf syndrome, no. Esophageal tear, no. Esophageal tear, no. The correct answer is erosive gastritis. Erosive gastritis, please. Note that very well. Erosive gastritis. That's the correct answer. Okay, let's go to the next one. Doctors, please, I want to proceed. Is that okay? Erosive gastritis. I want to proceed. Is that okay? Erosive gastritis. Okay, good. Now, you have a patient who maybe the question stem is telling you noted portal hypertension, the dilated veins on endoscopy, 16% mortality, and they have a high risk of rebleeding. What's the diagnosis? What's the diagnosis? What's the diagnosis? Portal hypertension, dilated veins when you do your endoscopy, 16% mortality plus high risk of rebleeding. I see a lot of doctors writing esophageal varices. So it can be esophageal varices or gastric varices, esophageal variceal bleed or gastric variceal bleed. Thank you very much. Let's move on. This patient has repeated vomiting. And when you do your endoscopy, you see longitudinal tear at the gastroesophageal junction. And then you see bright red hematemesis. Repeated vomiting, that gives you a clue. Longitudinal tear, that gives you the second clue. And this tear is at the gastroesophageal junction. That gives you another clue. And the patient has bright red hematemesis. That gives you another important clue. What is the diagnosis? What is the diagnosis? Okay, sure. Mallory-Weiss tear is what I see. Mallory-Weiss tear. So please, doctors, I need you, as we are going through this, I need you to start picking all these clues. All these clues. Repeated vomiting. Why? It increases the intra-abdominal pressure, right? And then as the vomitus is coming from the stomach, which has a wider caliber, it's trying to go through the esophagus, which has a smaller caliber. And because of that, there's a longitudinal tear in the esophageal wall. Boom. The patient has bright red hematemesis. Okay. Now, you get another patient. This patient has a critical illness. So maybe the patient is in the ICU. And it looks like the patient's body is responding to the stress of that critical illness. And then what you see on endoscopy is superficial gastric erosions. You are told in your question stem, superficial gastric erosions. This patient is in the ICU. The patient has critical illness. What will be your diagnosis? Doctors, what will be your diagnosis? What will be your diagnosis? Okay. I see doctors writing stress ulcer. Beautiful. So that is it. So you see the way we are using various clinical vignettes to really be able to tell what is happening. Stress ulcer. Okay, good. Now, this patient has vascular malformation. This new patient, vascular malformation. And then when you do your GI scope, you realize that there's fragile vessel rupture. Vascular malformation plus fragile vessel rupture. What then is your diagnosis? Vascular malformation, fragile vessel rupture. What is your diagnosis? Vascular malformation, fragile vessel rupture. What is your diagnosis, please? I want to know. I want to know. Doctors, I want to know. What is your diagnosis? What is your diagnosis? So I see Dr. Mosima says angiodysplasia. Does somebody agree with her? Looks like this one. I'm not seeing so many answers. The answer is arteriovenous malformation. Arteriovenous malformation. Arteriovenous malformation. So please, if you have to see a patient, upper GI endoscopy shows vascular malformation plus fragile vessel rupture. A vessel which was very fragile, it ruptured. What's the diagnosis? Vascular arteriovenous malformation. Next one. Unexplained upper GI bleeding. And you note recent progressive unexplained weight loss. There's a part of this equation I should have added which will give the question away. So I took that out. Unexplained upper GI bleeding. And you notice recent, progressive, unexplained weight loss. Okay, good. Dr. Mosima says cancer. Dr. Aterik Goel also says cancer. Will somebody want to jump on the cancer bandwagon? The correct answer is malignancy. So it can be esophageal malignancy, gastric malignancy, even the early part of the duodenum malignancy. Okay, good. Now, I have another question for you. This patient has a history of aortic graft. The patient had an initial bleed, which we call a herald bleed. And then it stopped. And then now, that patient now is so much blood coming from the mouth. You go into your board exam, you are presented with this particular case. What diagnosis are you going to think about? The patient has had an aortic graft, self-limited herald bleeding. So it came, stopped, and then now when it came again, boom! What diagnosis are we talking about? So Dr. Aterik says arteriovenous fistula. Who else has a different diagnosis they want to add? Dr. Aterik says arteriovenous fistula. And I'm asking, who has a different diagnosis? Who else has a different diagnosis? Okay, so I also see aortoenteric fistula. Okay, so that is the truth. The correct answer was gotten by Dr. Nomad, which is aortoenteric fistula. So in aortoenteric fistula, the board will tell you the patient has had an aortic graft. There was an initial bleed which stopped. And then now there's massive bleed. That is aortoenteric fistula. Doctors, I have a question. With the way we broke the concepts down, please, does it make sense? Did it help? The way we took time to break the concepts down. So now you should be able to identify a patient with aortic, esophageal, gastric, or duodenal cancer. You should be able to identify a patient with peptic ulcer disease. You must be able to identify erosive gastritis. You must be able to identify variceal bleeding based on the clinical presentation. So not every red blood from the mouth is as a result of Mallory Weiss or Bohave syndrome, as people were typing in the comment section, right? There are various forms or various causes of upper GI bleed that we need to master. Okay, now let's continue the game. So, how are you going to take a history of a patient with upper GI bleeding? How are you going to take a history of a patient with upper GI bleeding? The truth is that the history can mislead you, because in 14% of cases of upper GI bleeding, it looks like lower GI bleeding, where the patient may have bright red maroon stool. But why are you getting bright red maroon stool? Because most of the time, the bleeding is torrential. It's coming a lot. So it does not have the time to form that so-called dark tarry stool that many of us know upper GI bleeding for. So, what's the presentation? You have a patient who develops hematemesis, that is vomiting blood. That is the classic presentation of upper GI bleed. Now, if you see that the patient is presented as somebody who has coffee ground emesis, coffee ground vomiting, then that means that the kind of bleeding they are having is a slower form of bleed. So pure blood, hematemesis, is the classic upper GI bleed presentation, right? Now, what if you see that the patient has melena stool and the patient is less than 50 years? It should give you the clue that this is highly suggestive of upper GI bleed. And then bright red stool can still be as a result of upper GI bleed. That's why we said that 14% of cases of upper GI bleed can present with bright red stool, right? Okay, good. Now, there are subtle presentations patients present with upper GI bleed. For example, they can be hypotensive because they are losing blood, right? So their blood pressure will drop. And then a compensation of that can be tachycardia. But as the class goes on, you realize that there are some situations where you can have a patient with upper GI bleed, but the patient will have bradycardia. We call that paroxysmal bradycardia, but we've not gotten there yet. I will talk about that so that when you see that in your board exam, you are not confused about it. Now, as you know, the patient is losing so much blood, the patient can then develop angina. What do I mean by that? So, can you imagine somebody is losing so much blood and the heart is having to do more work to pump more blood to the rest of the body, the little blood left, right? And so the heart starts working, and then the patient starts developing chest pain, angina. And then the patient can also become syncopal. The patient can develop syncope. And then, of course, if you are losing blood, you can be weak. And then there can also be confusion. And at last, if it is not dealt with properly, the patient can develop cardiac arrest. Cardiac arrest. Doctors, I have a question. With these features and the previous slide, where we're talking about hematemesis, coffee ground emesis, melena, and bright red or maroon stool, are you okay? Are you okay? Before we move on to the next level, upper GI bleed. Are you okay with the foundation we've laid? I need responses. Are you okay with the foundation we've laid? Okay. Beautiful, beautiful, beautiful. Good. So let's continue the class. So what are mimics of GI bleeding that you cannot miss? Mimics, things which can mimic GI bleeding that you cannot miss in the exam. Mimics, and what in the lab tests will tell me that this is a mimic, so that when the board, those who are setting your questions, present something to you, you can be able to tell me that no, this is not an actual GI bleed. Okay, so let's try this. There is a medication that a patient ingested, and after the patient ingested that medication, the patient has developed black stool. It looks like melena, but when you do the guaic test, so the guaic test it's a test we do on stool samples, which helps us to know whether there's blood in it or not. So everything about the stool looks like an upper GI bleed. But then the history tells you that the patient took a unique medication. The patient after that developed black stool. It looks like melena. But when you do the guaic tests, which should tell me that there's blood in the stool, it is negative. Therefore, there's no blood in the stool. So in other words, I'm asking, which medication can make the stools black? Which medication can make the stools black? Said that if you are not careful, you will confuse that with an upper GI bleed. I see doctors typing iron supplement. Yes, so that can be iron supplements, which is mimicking melena. Iron supplement, which is mimicking melena. Okay, next one. This time the patient took food and the stool is red. It looks like hematochezia, but then guaic is negative. This time it is not a medication, it is food. And the patient took that, and now the stool is red. It looks like hematochezia, and the guaic is negative. What food will make the patient's stool look red? Okay, Dr. Joanna de Cruz, beautiful. People are writing beet. So that is beet, which is mimicking hematochezia. So doctors, you see what we are doing? We've learned the features of upper GI bleed. Now we've come to medication, things which can mimic upper GI bleed. But how do you know that this is not upper GI bleed? When you do your guaic test and the guaic is negative. Okay, so that is beets. Okay, so now let's go on to try some questions. You have a 42-year-old man who presents with black tarry stools. He denies vomiting. Which findings would make an upper GI source most likely? Most likely. A, age under 50 years with melena. B, guaic negative stool after iron injection. C, aortic graft history with a herald bleed. D, history of chronic hemorrhoids. And E, beets injection with red stool. Which finding would make an upper GI source most likely? Is it A, is it B, is it C, is it D, or is it E? What's the correct answer, doctors? What's the correct answer? Tell me, what's the correct answer? So I see that there people are torn between A and C. That is age under 50 years with melena, and C is aortic graft history with herald bleeding. And the correct answer is A. Melena in patients less than 50 years strongly suggests upper GI bleed even without hematemesis, right? Okay. Next question. You have a 45-year-old alcoholic man who presents with hematemesis. Which of the following conditions is most strongly associated with his alcohol use? Which of the following conditions is most associated with his alcohol use? A, Mallory-Weiss syndrome only. B, esophageal varices only. C, peptic ulcer disease, erosive gastritis, and varices. D, stress ulcer. E, aortoenteric fistula. What's the correct answer? What's the correct answer? Is it A? Is it B? Is it C? Is it D? Is it E? What's the correct answer? And I see a lot of doctors going for C. So alcohol use, please write this down in your book. Alcohol use is linked to peptic ulcer disease, erosive gastritis, and varices. Alcohol use is related to peptic ulcer disease, erosive gastritis, and varices. Doctors, please, is that okay? Is that okay? Can we move on to the next thing? Is that okay? Now, let's talk about a physical exam in a patient with upper GI bleed. The classic presentation so far as physical exam is concerned is that you will see that the patient is hypotensive and tachycardic. Heart rate is high, blood pressure is low, right? But then there can be subtle signs. And one of those subtle signs is that the pulse pressure will be decreased. And then the patient will have tachypnea, increased work of breathing, tachypnea. Now, some people may tolerate large blood loss with little change in their vitals. And remember that when I was teaching, I mentioned something we call paradoxical bradycardia. It doesn't make any sense for a patient who has upper GI bleed to develop bradycardia. But paradoxical bradycardia can occur in a patient who has developed profound hypovolemia. So if the bleeding is so much, then that patient can move from tachycardia to bradycardia. We call that paradoxical bradycardia because we know from science school, we know from medical school that so far the patient is losing blood, the patient must be tachycardic. So far the patient is losing blood, the patient must be tachycardic. However, if the bleeding is so much, they can develop what you call paradoxical bradycardia. Okay, so we are going to go back to our equations again. Doctors, I have a question. Are you okay with the fact that we use equations in our teaching? Are you okay with it? Because I feel that helps to get things stuck in our minds more. So are you okay that we do equations? Please let me know. Are you okay that we do equations? We do equations to help us, so that it's not like just all the time, just question, answer, but we're going to use equations. So let's start with the first equation. Patient has upper GI bleed, there's hypovolemia, the peripheries are cold, there's clammy skin. This one, everybody must know. Upper GI bleed with hypovolemia, cold peripheries, and clammy skin. What is the diagnosis? What is the diagnosis? Upper GI bleed with hypovolemia, with cold peripheries, and clammy skin. What's the diagnosis? Dr. Joanna, yes, shock is true, but what kind of shock? What kind of shock? And the correct answer is hypovolemic shock. Hypovolemic shock. Next one. I intentionally took one of the features of this particular equation out. So, upper GI bleed, the patient has spider angiomata, there is palmar erythema, there's also gynecomastia. What is the underlying cause of the GI bleeding? Upper GI bleed, spider angiomata, palmar erythema, and gynecomastia. What is the underlying cause of the GI bleeding? Tell me. Good. I see people writing cirrhosis and all those things. So liver disease, right? Chronic liver disease. And for your board exam, you must also be able to tell the features of chronic liver disease. You must be able to list at least 15 of them, right? Palmar erythema, finger clubbing. So if you start from the hand alone, palmar erythema, finger clubbing, Dupuytren's contracture, right? And then you go to the skin, you see some scratch marks there. You look at the skin, there is jaundice. You move to the head, you check the eyes, there's scleral icterus, right? The eyes are yellowish. You check the jaw, parotid enlargement. You come to the chest. If it's a male, gynecomastia. You see spider angiomata. You can also see telangiectasia. You go to the abdomen. You look at the abdomen is enlarged because of the ascites. There's liver enlargement, hepatomegaly. There can also be splenomegaly. There's shifting dullness if there's ascites in the abdomen. There can also be fluid thrill if the ascites is a lot. If you look at the groin, even before you get to the groin, if you look at the pubic area, if it's a male, they will develop female hair distribution. You look at the genitals, you realize that the testes have become atrophied. Then you look at the legs, you realize that the patient may have scratch marks and then the patient may have pedal edema. So this is what I'm talking about. If you have a patient with chronic liver disease, you must be able to start from hand to the leg. So you go from the hand all the way to the head, all the way to the leg. What are the features? And you can also develop caput medusae. That's true. Okay. Now, you have a patient with upper GI bleed. There is petechiae and there is purpura. So upper GI bleed and petechiae is, this dot-like bleeding in the skin. And purpura is like all these blotches on the skin. What is your diagnosis? What is your diagnosis? What is your diagnosis? What's your diagnosis? Upper GI bleed in a patient with petechiae and purpura. Beautiful. Dr. Enna says bleeding disorder, coagulopathy. Some say ITP. What's the correct answer? What's the correct answer? It's a coagulopathy. The patient has a coagulopathy. That is why the patient is having all these features. All these features. Okay. Next one. Upper GI bleeding. Pigmented mucocutaneous spots on the lips, in the oral mucosa. And then it is also thrown in that this patient has GI polyps. What's the diagnosis? I'm getting my board. So, upper GI bleed plus pigmented mucocutaneous spots on the lips, in the oral mucosa, and gastrointestinal polyps. What's the diagnosis, doctors? What's the diagnosis? Please tell me. What is the diagnosis? What is the diagnosis? What is the diagnosis? Upper GI bleed, pigmented mucocutaneous spots on the lips, on the oral mucosa, and you're also told that the patient has GI polyps. Well, Dr. Norman said PJ syndrome. That's Peutz-Jeghers, right? Peutz-Jeghers. Beautiful, beautiful. So, first assignment for today, please learn the features of Peutz-Jeghers syndrome. I'm writing it on my board. Please make sure that you are learning the features of Peutz-Jeghers syndrome for your board exam. Make sure that you've learned the features of Peutz-Jeghers syndrome and you're not missing any of that. Peutz-Jeghers. Make sure that you learn the features of Peutz-Jeghers syndrome. Please make sure you learn the features, okay? Please make sure you learn the features of Peutz-Jeghers syndrome. Make sure that you learn the features of Peutz-Jeghers syndrome. So that's the first thing I want you to learn. And we've learned today that Peutz-Jeghers syndrome, how will the patient present? Upper GI bleed. The patient will have pigmented mucocutaneous spots on the lips, in the oral mucosa, and then the patient will have GI polyps. Peutz-Jeghers. Okay? Peutz-Jeghers syndrome. Okay. Next one. This patient has upper GI bleed, but then we noticed that other family members have it. And then this patient has mucocutaneous telangiectasia. And the patient has had a recurrent bleeding. And this recurrent bleeding, the patient has not just had it in the GI tract, but the patient also has it from the nose. Epistaxis. Recurrent GI bleeding. Other family members also have it. And the patient has mucocutaneous telangiectasis. Doctors, what's the diagnosis? What's the diagnosis? I want to know. So, first assignment, Peutz-Jeghers syndrome. I'm writing it down. Peutz-Jeghers syndrome. Next one is this one, upper GI bleed with a hereditary pattern, mucocutaneous telangiectasia, and recurrent bleeding. The patient has even had epistaxis before. What is the diagnosis? The diagnosis is what we call the Renu-Osler-Weber syndrome, or hereditary hemorrhagic telangiectasia. So that one too, I need you to learn it today before you sleep tonight. Make notes on them. Send me a voice note on WhatsApp +1 306 891 5649. So it is Renu-Osler-Weber syndrome, or HHT, hereditary hemorrhagic telangiectasia. So that's the second assignment for today. Peutz-Jeghers syndrome, and then Renu-Osler-Weber syndrome, or hereditary hemorrhagic telangiectasia. Doctors, I don't want to rush the class. Are we all tracking together, please? I love this board. Are we all tracking together, please? Please, I want to know, are we all tracking together? I really want to know. Are we all tracking together? Are you picking up some concepts today that you might not have picked up if you were learning on your own? So you must be able to tell. Renu-Osler-Weber syndrome. If you see in a board exam, you must be able to tell. Okay, next one. Upper GI bleed with a patient with intestinal polyps. And then you see skin soft tissue tumors, like an epidermoid cyst, a fibroma. What is your diagnosis? Upper GI bleed plus intestinal polyps plus skin or soft tissue tumors like epidermoid cyst or a fibroma. What's the diagnosis? What's the diagnosis, doctors? What's your diagnosis? Upper GI bleed plus intestinal polyps plus skin or soft tissue tumors, epidermoid cyst or fibromas. What the diagnosis? Okay, the normal says Gardner's syndrome. Doctors, does anyone have a different answer? Looks like we are going a bit deep. Yes, and that's why I'm saying that, when you're learning for these board exams, it's not just enough to say, oh, upper GI bleed, I'm going to give blood, I'm going to give octreotide, blah, 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 blah. No, these are the things which can get you. So does somebody have a different answer than what Dr. Nomad has put down as Gardner's syndrome? And the correct answer is Gardner's syndrome. So doctors, if you've not learned these 3 things, I need you to master them today. I need to master them. Number 1, Peutz-Jeghers syndrome. Number 2, Renu-Osler-Weber syndrome, or hereditary hemorrhagic telangiectasia. And then number 3, Gardner syndrome. I need you to learn them. Learn all 3 of them very well. Okay. Doctors, how has the class been so far? I want to know. How has the class been so far? How has the class been so far? How has the class been so far? Upper GI bleed. We've looked at clinical presentation. We've looked at why do we call it upper GI bleed. We've looked at risk factors for increased morbidity, mortality. We mentioned 3 things. We've looked at upper GI bleed mimics. We've learned that how to separate proper upper GI bleed from a mimic is for you to do a guaic test. And we've learned that patients who are taking iron, who are taking beetroot, all of them can present with dark stool, but all of them will have guaic negative. And we've learned certain critical points today. Okay, good. So now let's get on to the active recall. But before the active recall, I want you to know, yes, we are learning a lot on YouTube, but if you want to grasp things even more quickly, we have a program for you. We have a program for you. It's a 6-month program, okay, where you're going to get your own question bank, you're going to get your own portal, you're going to get pre-recorded lessons that you need to complete before you come to class. And then when you come to class, we will grill and drill and prepare you, where we are going to bombard you. Then, after that, we record that lesson and you can use it for your revision. You also get what you call med bullets. So med bullets is like, the final revision that you need to do for your exam. You don't need to worry about it. We've already done that for you in a video format. And then we also have what we call med drills. So every month we put 2 days aside, every Thursdays and Sundays, and then we go through a drill. And then every 2 weeks as well, we'll conduct a mock exam for you, live mock exams. Meanwhile, you also have mock exams in your portal, right? But every 2 weeks, we conduct a live mock exams. And I see that helps to prepare a lot of candidates very well for the exam. So now let's go in to do the active recall. And to get 6 months access, it's only $2,200 one-time payment. $2,200 one-time payment. Or you can decide to pay it monthly, $420 every month. Okay, any of the options is good, and we will take it. Okay, so let's do some active recall. Where does upper GI bleeding originate anatomically? Let's do it quick, and then we will end the class, because I have another class with our NAC OSTI students as well. They are preparing. They are in the last week of their preparation for the exam, so we're just going to meet them and have a moral booster for them. So, where does upper GI bleeding originate anatomically? Doctors, please type in your answers. Let's go. Where does upper GI bleed originate anatomically? Anatomically. Proximal to the ligament of triads. Beautiful. Proximal to the ligament of triads. Next one. What 3 factors increase morbidity and mortality in upper GI bleeding? What 3 factors increase morbidity and mortality in upper GI bleeding? Please list them quickly. What 3 factors increase morbidity and mortality in upper GI bleeding? What 3 factors increase morbidity and mortality in upper GI bleeding? And the correct answers are older age, coexisting organ disease, and recurrent hemorrhage. Old age, coexisting organ disease, and recurrent hemorrhage. Next question. What 2 findings classically suggest an upper GI bleeding source? What 2 findings classically suggest an upper GI bleeding source? What 2 findings classically suggest an upper GI bleeding source? What 2 findings classically suggest an upper GI bleeding source? And the answer is hematemesis and coffee ground emesis. Hematemesis or coffee ground emesis. Yeah, Melina stools can also present as well. Hematemesis and coffee ground emesis. Hematemesis and coffee ground emesis. Okay, next one. In patients less than 50 years old, what symptoms strongly suggest an upper GI bleed source, even without hematemesis? In patients less than 50 years old, what symptoms strongly suggest an upper GI bleeding source, even without hematemesis? In patients less than 50 years old, what symptoms suggests What symptoms strongly suggest an upper GI bleed source even without hematemesis in patients less than 50 years old? What symptoms strongly suggest an upper GI bleeding source even without hematemesis? And the correct answer is melena. Beautiful. So Dr. Saha got it right. Melena stools. Okay. Which medications increase the risk of upper GI bleed? Which medications increase the risk of upper GI bleeding? Which medications increase the risk of upper GI bleeding? Which medications increase the risk of upper GI bleeding? Okay, I've seen NSAIDs, NSAIDs, NSAIDs. So you can have salicylates, you can have glucocorticoids, you can have NSAIDs, and you can even have anticoagulants. Salicylates, glucocorticoids, NSAIDs, and anticoagulants. Salicylates, glucocorticoids, NSAIDs, and anticoagulants. These all increase the risk of upper GI bleeding. Okay, now, which substances or foods can mimic GI bleeding but will be guaic negative? We are basically doing active recall. Which substances or foods can mimic GI bleeding but will be guaic negative? Guaic negative. Will be guaic negative. Guaic negative. That should be guaic negative. Doctors, please, if you've not subscribed to our channel, please subscribe because we have a lot of goodies coming your way. We have a lot of goodies coming your way. We are currently at 3,308 subscribers. Please, by the end of this stream, let's move it to 3,350 subscribers. 3,350 subscribers. Now we are sitting at 3,308 subscribers. So please, if you've not subscribed, just go to the YouTube subscribe button right now. Click on the like and the subscribe button and also share with your friends so that they can also subscribe. Okay. Which substances or foods can mimic GI bleeding but will be guaic negative? Guaic negative. Guaic negative. Guaic negative. And the correct answers are iron, bismuth salicylate, and beads. Iron, bismuth. Bismuth is usually used for patients with, gastritis and the rest, right? It lines the stomach lining. Iron, bismuth, and beads. Okay, so doctors, please. For further studies, we need to now get into laboratory investigations, diagnostic studies, management, and disposition. Okay, and of course, we can't cover everything in this class. So we will do that in a future class. But I hope that today's class was helpful. And doctors, usually after these webinars, I know that some of you want to reach out to me. I have a class in 30 minutes. So if you want to reach out to me right now, you are interested in joining the program right now, just give me a call by WhatsApp on +1 306 891 5649 +1 306 891 5649. Thank you very much, and sorry for the initial mishap where the stream stopped, but I'm happy that we're able to get ourselves together again and get things going. Doctors, thank you very, very much. Please, I'm open for any question. So if you have any question, just drop it in the comment section. I'll read it and then explain your concern. If not, then we'll meet sometime later. On Thursday, remember you have a QE1 class. On Thursday, you have a QE1 class. And if you want to speak with me, my phone number is +1 306 891 5649. Get in touch. Let's get going. Doctors, thank you very much. Have a good day. Bye-bye.